Very pleased to have the opportunity to speak to you all this morning. As my presentation title suggests, we're going to be talking about the cost effectiveness of HAART expansion since the advent of HAART up until 2010, which is when the Seek and Treat for Optimal Prevention HIV/AIDS program was implemented. I should point out right now I have no conflicts of interest to declare. Briefly, during my presentation, I'll give you some background on health economic evaluation, what its focus is and how we use it. I'll speak very briefly about STOP because I suspect many of you will be have a good understanding of what was done. I'll talk about the transmission model, the model we built to answer our study question. I'll talk about the results of our analysis. And I'll save some time to talk about next steps, which of course will be of greatest interest to me because I'm currently working on them. Health economics is really drawn from the broader field of welfare economics, which suggests that as a government payer, we should be focused on maximizing social welfare subject to constraints. Constraints on technology, human capital, financial capital, and others. Economic evaluation is about comparison of alternative strategies to determine the greatest value for money, and this is really about defining evidence for resource allocation decisions to maximize the health of the population. And our primary outcome in health economic evaluation is the incremental cost effectiveness ratio. So this is the ratio of differences in costs and measures of effectiveness of a new technology or a new strategy versus existing, or in our case, what we have done compared to situations where perhaps we didn't scale up HAART as aggressively as we did in this province. And I should point out here that the consensus measure of effectiveness in health economic evaluation is the quality adjusted life year. This is a preference-weighted, societal preference-weighted measure of overall health. And it combines aspects of both morbidity and mortality, which are key to consider in HIV/AIDS. And the use of this quality it really comes back to our theoretical standpoint of maximizing social welfare. In terms of health care, we are maximizing health subject to constraints. So very briefly, the Stop HIV/AIDS pilot project was initiated in 2010, first focused on Vancouver coastal and northern health, and it was a partnership between the various stakeholders in HIV/AIDS to work collaboratively to increase HIV testing and reduce HIV-related morbidity, mortality, and transmission. There was a health economic evaluation component attached, which was really based on comprehensive provincial, clinical, and health administrative database linkage. So this was in addition to increased efforts for surveillance, and I'll be presenting on the first part of this economic evaluation component. The next will, of course, be the evaluation of the pilot itself and future initiatives. So in economic evaluation in HIV/AIDS, you basically have two types of studies, drug A versus drug B type of comparisons, and then more population level comparisons of strategies to scale up HIV testing and treatment. The problem is with these secondary types of evaluations, they're typically based on hypothetical data, and they're projecting far out into the future. We have a unique situation here, and really our question was defined by the ministry when STOP was implemented. Based on what has already happened, was what we did cost effective? Okay? So in order to do that, we wanted to take advantage of the linked population level data and surveillance systems that we have to answer this question. And really these databases are quite possibly the best and most comprehensive across the world. So we wanted to take advantage of these to get a true answer to this question, which has really only been addressed hypothetically elsewhere. So our primary objective, again, is to determine the cost effectiveness of HAART scale-up in BC. But of course, in economic evaluation, just like in epidemiological studies or randomized controlled trial, the question is, what is the comparator? Cost effective compared to what? And in this case, we've had quite a lot of efforts, including this biannual update, to scale up antiretroviral treatment, engage physicians, and have a centralized focus on improving HIV care. And so we wanted to compare what actually happened versus hypothetical scenarios where there was constrained access. So these hypothetical scenarios represent reductions in the instantaneous probability of an individual accessing HAART in contacts with physicians. So you can consider these constrained access scenarios as perhaps alternate versions of what might have happened in BC had we not been so aggressive in our efforts to scale up treatment and reduce the burden of this disease. So about the model, so our process was first, of course, we had this large health administrative database. We wanted to define and validate a cohort of people living with HIV/AIDS. And of course, this STOP initiative allowed us to link the POP Data BC database, including DAD and the MSP databases, which allowed us to capture a larger population of people living with HIV/AIDS that we hadn't studied previously. Once we did that, we wanted to estimate some of our key model inputs with a focus on how they changed over time. So CD4 progression while on HAART, costs of highly active antiretroviral therapy, and costs of health resource utilization among people with HIV/AIDS. We then wanted to adapt and modify an existing HIV transmission model and calibrate it to characterize the BC epidemic. Now this would have made our actual practice scenario. And then we wanted to validate results of the model against known epidemiological indicators. Again, we are operating in perhaps the most data-rich environment in the world. We wanted to make the most use of all of that data and incorporate as much of it as we could into our model. So as for the first step, we wanted to define our cohort. We had data not only from the BC Centre for Excellence, but also the CDC on HIV testing and the Ministry of Health. So we had mentions of HIV positivity in hospitalization and outpatient care records. And this allowed us to see both confirmed and unconfirmed cases, and we applied a case finding algorithm to come up with a total cohort to study over this time. And this was basically our denominator for all of our subsequent statistical studies. One of the first things we looked at, and this study was actually published in J-AIDS in 2013, we looked at the probability of CD4 progression among people on HAART. Now, we looked at several different strata, CD4 greater than 500, 350 to 499, 200 to 349, and less than 200. Basically, the lines that you see that are going up or flat or are probabilities of either staying in the same state or improving, while the lines that are going down, shaped downwards, are probability of progression. So CD4 declining over time. So you can see these things have improved pretty immensely in some cases over time, which is really testament to the improved effectiveness and adherence to the medications. Next, we look at the changing costs of highly active antiretroviral therapy. And to do this, and I should say we made a point of disaggregating HAART costs and non-HAART costs, because actually there are two very different things happening there. So you can see in the left panel, the dark black shaded group is the proportion of the population population of HIV positives who initiated antiretroviral therapy before 1996. So they initiated mono or dual drug therapy. Those folks, and you can see in the right-hand panel, they are the top line, the top dotted line. over time, they're making up a smaller and smaller proportion of the overall population, and they also have the highest cost. So just by virtue of the change in the epidemic, the per-person cost of highly active antiretroviral therapy, irrespective of changes in first-line therapy and everything else, but we believe these per-person costs are going to be going down. In terms of costs of health resource utilization, it was a different story. It's largely, as you can expect, based on current CD4 count. So the top line in the right-hand panel, these are the costs of non-HAART health resource utilization for people with a CD4 less than 200. And you can see there, those costs are considerably higher than each of the other groups, and there's really no pattern over time. So this really underlines the need for highly active antiretroviral therapy to slow progression to this late-stage disease. So the next step was fitting these parameters into our transmission model. And I should say that there are dozens of HIV transmission models out there. We felt no need to develop something new. We wanted to adapt an existing model, and this was a model developed by Elisa Long et al. At Stanford, and it was initially built for the US population. So it starts with a group of susceptible individuals which go through stages of screening and not having been screened. And they can progress to an infected state, at which point their disease progresses. There's no improvement in disease progression once if they're infected and not on HAART. And there are 4 key CD4 strata, and of course, the lower your CD4 count, the higher your chances are of unsuppressed viral load, and so the higher your chances of transmission are. After infection, there's a monthly probability of being diagnosed, and once you're diagnosed, your chances of transmission are decreased. Finally, after diagnosis, you can progress to being on treatment, and you can see that the on-HAART states, you can both, your CD4 can decline and it can also improve. And a key modification in this model was the ability for people who were on HAART to actually drop out subsequently. And this was all based on population level data, and it was allowed to change over time. Now, so within this structure, we had 4 key risk groups, which were men who have sex with men, injection drug users, injection drug using men who have sex with men, and heterosexuals. So each of those 4 risk groups has a set of states that they can progress through. So some overall key features, this was a dynamic model, meaning that it was based on the population, and the outcomes changed based on the number of HIV positives, which influenced the rate of HIV transmission. It was cohort-based. It was compartmental. You see people move between these compartments, and it was deterministic. So when it comes to HIV transmission, we assumed a proportional mixing between groups. So to differentiate this, had we assumed homogeneous mixing, then it would have been that any partner was equally likely to infect another in any group. If there was no consideration of mixing, there'd be no transmission across risk groups. But we know that doesn't happen. Proportional mixing allows for transmission between the risk groups proportional to how often they contact one another. So this really allows for a nuanced characterization of HIV transmission. It basically allows us to be more realistic about how transmission is actually happening. And basically within each of these 4 strata, you could transmit to another group based on either homosexual contact, heterosexual contact, or injection drug use. So how did we incorporate changes over time? It's a key question because, as you know, if you've been attending this antiretroviral update, a lot has changed over time. So first of all, we incorporated treatment initiation guidelines. So if you had a CD4 count of over 500 in the early 2000s, when initiation guidelines suggested that you couldn't get onto treatment until your disease had progressed, until your CD4 was less than 200, then you weren't allowed entry into those states. And so that changed according to our biennial IAS USA guidelines. I've already showed you slides on HAART disease progression, antiretroviral and non-antiretroviral costs. These were based on population level data in BC. So all these changes in disease progression, HAART costs, non-HAART costs, they were all incorporated. HIV testing rates we have very good information on from the CDC, and that was also incorporated. HIV risk behaviors are of course a little more difficult to estimate. However, we use proxies of methadone maintenance treatment initiation for the probability of shared injection and non-HIV STD rates for, as a proxy for changes in sexual risk behavior. And this really, this was a game breaker for us. Basically, incorporating these changes in HIV risk behaviors allowed us to simulate the epidemic to a very specific level. And we also considered underlying population trends in terms of number of people within each of the, number of susceptible individuals in each of the risk groups. So I'll drive home the point again. So this was our key modification really in terms of risk behavior. So in panel A we have the OST or methadone maintenance treatment initiation index, and you can see in panel B to the right of it is really the inverse, which we took as a proxy for the mean monthly number of shared injections. By the same token, the non-HIV sexually transmitted infection rate is in the bottom left panel, and we use that to proxy for changes in the probability of condom use by partnership for each of the groups. So these are inverse mirror images from left to right. Once we did that, we were able to validate our model to a very specific level. So in the top panel, the purple line is our model estimated overall prevalence, and the blue line is the PHAC estimate for prevalence for our province. In the right panel, we have the number of diagnosed, the true number in red, and the modeled estimate in blue. And on the bottom, we have our estimated HIV incidence. The model number, the model trend is in red, and the PHAC estimate is in blue. And we are able to sort of simulate incidence within each of the risk groups to a very specific level. So these are 4 of the, I believe, 10 different levels at which we validated our model. So we were basically able to replicate the HIV/AIDS epidemic to a very specific level. And just briefly, some of our results. So even though we were looking at 75% and 50% access, basically, if access is denied over and over, there's going to be a greater buildup of diagnosed patients who want access to treatment. So the total number of person years on HAART is only about 10% lower in the 75% access scenario and 20% lower in the 50% access scenario. But in any case, observed access, what really happened, decreased the number of incident cases, decreased the number of deaths. There was a lower number of prevalent cases as of 2010. And even within, and I should tell you, the initial perspective of focusing on 1997 to 2010, this is very constrained. Why? Because HIV is an infectious disease, and so if you want to capture the total benefits, you have to consider a much longer time perspective to capture the secondary preventative benefits. So even within a very narrow time frame, and taking a third-party payer perspective, which is not accounting for productivity gains that you acquire from HIV. We found observed access was highly cost effective. So the number there, 23,000, this compares to, so there's a pretty wide consensus on what an acceptable threshold is for a cost per quality gained, which is 1 times GDP per capita. If you're below 1 times GDP per capita, you can consider your intervention as being highly cost effective. If you're 3 times below GDP per capita, you're still cost effective. And above 3 times GDP per capita, you're not cost effective. So, and Canada's GDP per capita right now is 52,000. So you can see even at that level, even within a constrained scenario, considering a constrained perspective, HAART scale-up, as it was observed, was highly cost effective. Now, if we take into account a societal perspective, where we're allowing for, we're capturing the productivity gains, the strategy dominates constrained access scenarios, which means that costs were lower and health benefits were greater. And of course, if we extend the horizon, highly cost effective. So here's a plot of annual, so these are the annual year-over-year expenses of observed scale-up versus constrained access. So you can see we're only plotting from 2010 to 2035. And this is, and so that initial spike that you see is the increased cost of highly active antiretroviral therapy following guidelines that suggested to test regardless of CD4 count. So you see an increase initially, but 6-7 years later, you get to a point where your actual year-over-year expenses are lower. Why is that? Because disease progression is delayed and because new cases are prevented. So within a short span of time, the increased costs are reduced, and over a longer time horizon, we're looking at a present value savings of 25 million compared to slightly constrained access, and 66.5 million compared to 50% access. So these initial investment in treatment access are very quickly offset by savings in incidence and delayed disease progression. So one of the things this type of modeling activity allows us to do is to ask a number of what if questions. So what if there was a proportional constraint on HIV testing, right? So what if we weren't testing as aggressively? Well, we actually found a greater quality loss, which suggests that the observed level of testing that we saw in the province was also highly cost effective. Now, the really interesting questions are about the underlying risk behaviors. So what if we had not seen the decreases in injection risk behavior that were observed in the province? This is where it gets very interesting. So had we held injection risk behaviors constant over time, total cost would have been $42 million greater, and we would have lost 3,000 qualities. So I think the role of harm reduction initiatives in this province in the fight against HIV/AIDS have probably been understated. They had a huge impact, and we would be in a much worse state without them. In contrast, I showed you that there were increases in non-HIV STD rates, which suggests higher sexual risk behaviors. Well, what if that didn't happen? What if we had seen constant sexual risk behaviors at the time? Well, again, we would have been in a much better place, to put it short. So we would have seen lower healthcare costs and a loss of an additional loss of 1,000 qualities. So it's a bit of a mixed bag in that respect. We're grateful to see reductions in injection risk behaviors, but it was unfortunate to see the increase in sexual risk behaviors. So it gives us an idea of what we need to focus on in the future. Of course, we're going to be refocusing on sort of next steps. So taking us back to the point at which we received our population level data set. Once we constructed our cohort, we realized the first thing we should be doing, and the activity which would give us the greatest value is actually estimating our cascade of HIV care. And we did that. That was one of our first activities, published in Lancet Infectious Diseases, and right to this point, it stands as the only truly estimated cascade of care across the world. And we've now implemented it into our STOP quarterly reports to each of the health authorities. So not only we're getting this at the provincial level, we're estimating it for different health authorities and for different strata of individuals. And policymakers within these health authorities are aligning themselves in terms of how they should be intervening to maximize the cascade based on that empirical data, which is good. However, it's a bit of bit more complex than that. So we thought about this a little bit more carefully, and we're now refocusing on establishing the cost effectiveness of different interventions along the continuum of HIV care. And we published this paper earlier in 2014, which was really a review of the literature of the cost effectiveness of interventions along the cascade of care. And it's pretty sparse at this point. So to drive home this point of this paper, we consider a stylized example. We have two settings, setting A and setting B, with different cascades of care. We consider 3 interventions: an HIV testing intervention, a HAART reinitiation intervention, and a HAART adherence intervention. And we assume these interventions are equivalent in each of these settings in terms of the cost, effectiveness, and scale at which they're implemented. Well, just because of the different shape of the cascade, intervention 1 will be more cost effective in setting A because of the better subsequent linkage in that setting. Intervention 2 is going to be more cost effective in setting B because of the better subsequent suppression. However, this is mitigated by the lower linkage for those secondarily infected. And intervention 3 is going to be more cost effective in setting A because of higher level of leakage between the on-HAART and suppressed stages. So even if you have equivalent interventions in these two settings, and you can consider them health authorities, or even within a health authority, one risk group versus another, it's actually a different guidance in terms of what is your most cost-effective intervention. So we need to think about this carefully. And our latest work, which we're actually going to be presenting this summer at IAS, we consider a few hypothetical scenarios. We compare current practice to interventions which led to a 10% increase in testing, or a 10% increase in treatment uptake, or a 25% decrease in the rate of treatment discontinuation. And basically we found, to put it simply, there was differential value for equivalent investment in testing, treatment uptake, and retention interventions. And this is really dependent on the effectiveness of the intervention. It's dependent on the underlying epidemiology and the treatment cascade of the population that you're targeting with that intervention. And the key thing here is that both factors are going to change over time. And so you may have decreasing returns on investment for different interventions that you're implementing in the population. So primary care testing may be cost effective now, but as there are fewer and fewer HIV positive populations and HIV positive individuals in the population, it's going to become less and less cost effective. So the message is we need to be nimble, we need to adapt as our epidemic changes and as our level of care and our continuum improves. So our next steps are taking this model and testing it with actual figures from BC-based interventions. And I really focus on BC-based interventions because what we do here is going to be different than what's done in other settings, other provinces. There are a number of things that make us quite unique. We want to use a model to evaluate prospective interventions, and I've listed RETAIN, the RETAIN study, which some of you may know about. This is led by Rolando, and the E-host intervention, which is expanded HIV care and OST, which myself and my group are leading. And most critically, we want to incorporate this type of resource allocation guidance into quarterly monitoring reports. Basically, we think we can use our model and use it as to provide near real-time guidance on where resources should be allocated along the cascade of care, alongside the epidemiological reports in the STOP quarterly monitoring reports. So that's where we're headed. And I basically just wanted to acknowledge a number of people involved in the STOP HIV/AIDS initiative, and thank you all for your time.